Hello, and welcome to the first Caregiver Connection event, Beyond Treatment, the Emotional Side of Prostate Cancer Care Partnering. I'm Karen Schaefer from Fans for the Cure. We're excited to partner with the American Cancer Society to present this program in celebration of National Caregiver Day. Today, we honor the caregivers who lovingly support cancer patients, especially those experiencing the unique challenges of care partnering with men on the prostate cancer journey. Fans for the Cure is a nonprofit organization dedicated to raising awareness, providing education, and supporting patients with prostate cancer and their families. Our charity was founded by sportscaster Ed Randall in 2003, after he was diagnosed with the disease and successfully treated. His mission was, and still is, promoting the importance of early detection for best outcomes. Through Ed, Fans for the Cure has always enjoyed strong support from Major League Baseball and many other professional sports leagues and teams. Today, our partnership with professional sports organizations and teams provides opportunities to participate in prostate cancer awareness events or PSA screenings at about 10 stadiums and arenas a year. More importantly, it includes joining the teams and their official medical providers in their communities to raise awareness, provide education, and promote PSA testing. We also meet men and their families in the communities where they live at health fairs, churches, and free screening events almost weekly throughout the year. Media evaluator FeedSpot currently ranked our Stay in the Game podcast as number 3 prostate cancer podcast worldwide. Stay in the Game features interviews and conversations with doctors, researchers, and medical professionals sharing cutting-edge information. Survivors and others speak candidly about their experiences with prostate cancer. 2 years ago, we launched a women's podcast series where experts in psychology, relationships, intimacy, and caregiving address the specific issues and concerns of women living with partners or spouses on the prostate cancer journey. COVID forced our men's support group to pivot from in-person to virtual, and it quickly grew to include men from beyond the New York area. That success prompted us to establish a virtual women's support group for partners and spouses. This year, we will host 29 virtual men's support group meetings and 24 virtual women's support group gatherings. The Caregiver Connection Initiative and this program were inspired by the open and honest conversations that take place during the twice-monthly women's support group. We are pleased to have 3 distinguished caregiving experts with us today: Dr. Allison Applebaum, Dr. Andrew Roth, and Dr. Nicole Stout. They will address different aspects of caregiving and answer your questions that are posted in the Q&A chat. Without further delay, let's get started. Our first panelist is Dr. Allison Applebaum, a caregiving scientist, writer, researcher, speaker, and advocate. She serves as professor of geriatrics and palliative medicine and the director of the Stephen S. Elbaum Family Center for Caregiving at the Icahn School of Medicine at Mount Sinai Hospital. Previously, Dr. Applebaum was the founding director of the Caregivers Clinic at Memorial Sloan Kettering Cancer Center. It was the first program of its kind in the United States to provide comprehensive psychosocial care to family members and friends of patients in caregiving role. She is the author of the recently published narrative nonfiction book, Stand By Me, a guide to navigating modern, meaningful caregiving, in which she candidly chronicles her own experiences as a family care partner. Today, she's going to offer guidance for caregiving with dignity and managing the associated stress and distress with grace. She also is going to share her perspective that she has gained through her lived experience, coupled with her extensive research and clinical practice. Dr. Applebaum?
Thank you so much, Karen, for having me and for all of you joining, and to wish everyone a happy National Family Caregivers Day. It's the perfect moment for us to be coming together and honoring you who are caregivers. I want to take a zoom out lens and talk a little bit about who caregivers are and talk a little bit about the experience of what it is to be a caregiver. We know there are today at least 63 million caregivers in the United States, at least. So this is a significant number of caregivers, and it's a number that is increasing, especially as we are seeing a push to care at home that depends on family caregivers. We know that nearly 6 million of these 63 million caregivers are providing care to patients with cancer. And we know that the responsibilities of cancer caregivers are profound. Caregivers assist with activities of daily living and instrumental activities of daily living, all the things that you do to help your loved one, to take care of them, and to ensure that they can remain at home and live independently at home. Caregivers are increasingly performing medical and nursing tasks. This is something I'm going to turn back to a few times today. We are seeing a significant increase in these responsibilities, and importantly, these are responsibilities that were once assumed only by trained healthcare professionals, and too often caregivers are asked to perform them without training, education, or support. And it's invisible, but it needs to be stated that caregivers provide emotional support. And importantly, this is often at the same moment when they're no longer receiving the same level of emotional support they once got from patients. So oftentimes there's a mismatch in the support that is received. Now, on average, US caregivers are in the role for 4.5 years, but I want to acknowledge that in general, the cancer caregiving trajectory has been described as intense and episodic. On average, it's 1.9 years long. It doesn't mean that you might not be in the role for years and years and years, but on average, it's actually shorter than other types of caregiving journeys, like a dementia caregiving role. And yet we know it's particularly intense. Intense periods of leading up to a diagnosis, figuring out the right treatment, going for those first and second and fifth opinions, and navigating medical complexities and the many ups and downs. So it's often a very intense period of time. We also know that on average, caregivers provide care for 23.7 hours a week, but I want to acknowledge that for nearly 1/5 of caregivers, this is a full-time job, oftentimes conducted in addition to full-time paid employment. And in 2023, it was estimated that the annual economic value of caregiving was $600 billion. That is, if we put a dollar sign, a financial value on all of your efforts as caregivers, it accounts for $600 billion. Despite the fact we know that at least 1/4 of caregivers report high financial strain, and one study out of cancer caregivers found that nearly 1/5 go into poverty as a result of caregiving. And so there's a very significant disconnect between the value of all of your efforts and the financial toxicity you experience. And I also want to say, just last year in 2025, a study coming from the Mailman School of Public Health in collaboration with Otsuka said that 600 billion number is actually an underestimate, is closer to $890 billion. So the value of caregivers' efforts is very extreme. Now, not surprisingly, as a result of all of these responsibilities, the majority of caregivers experience what we call caregiver burden. This is a phrase I'm sure you have heard before. It is a catch-all phrase that refers to all the ways in which the caregiving role can potentially negatively impact the caregiver. The first component is psychological. Now, I'm a clinical psychologist by training, so this is the one that's particularly interesting to me. We know that diagnostic rates of anxiety, depression, and even post-traumatic stress disorder are higher in caregivers than the patients for whom they provide care. And this is why the support you're getting here and the support we hope you'll get in the future is so very important. Caregivers are also at risk for their own physical and medical problems: cardiovascular disease, poor immune functioning, fatigue and sleep difficulties, and even higher rates of mortality. I'm not saying this to scare you, but to acknowledge the fact that caregivers are very much at risk for their own negative physical outcomes. There's, of course, a financial component to burden I just mentioned, as well as a social component. Now, caregivers are historically incredibly isolated. The pandemic, of course, really exacerbated this, but I think for cancer caregivers in particular, who are caring for potentially immunocompromised loved ones, that isolation could become almost unbearable. I also want to acknowledge, perhaps this is the case for some of you, that even if you have a social support network, if you don't have any caregivers in that network, you may also feel isolated because sometimes it really takes another caregiver to understand what it's like to be a caregiver, which is why this environment is so important. And finally, when we think about burden, there's also a spiritual and existential component. The spiritual component is often a crisis of faith that one has. Why me? Why him? Why us? Why is this happening? He's been so healthy his whole life. He's eaten healthily. Why did we get this diagnosis? And the existential component is the distress that we all experience when we realize that we are human and we are mortal, and we and those we love will all eventually die. And certainly this distress can come up for caregivers. What I want to emphasize today is distress and burden is normal. So if any of the things that I said are things that you're experiencing, that's not necessarily a problem. In fact, as a psychologist, I get much more concerned when I meet a caregiver who says to me, I'm doing just fine in a very difficult situation. That's usually a sign there's some avoidance going on. But I do want to acknowledge that there are some signs that you should look out for that would say that maybe you're in need of professional help, or maybe the burden has gotten too overwhelming and we really need a problem solver around expanding your support. The first is if you find you just can't get out of bed in the morning, it's just too overwhelming to face the day, that is a great sign that it's time for support. If you find that the distress and burden you're experiencing is preventing you from taking care of your care partner with cancer, that of course too is a sign that you really need support. And of course, if you're ever having thoughts that life might not be worth living now or in some point in the future, that too is a real sign that it's important to look for help. And certainly we can talk about that during the Q&A. Karen mentioned that in addition to my professional work as a caregiving scientist, I've also been a family caregiver for my father, Stan Applebaum. He lived with Lewy body disease. He did not have cancer, though certainly in caring for him for over a decade, I learned many lessons. And what really stands out to me that I want to share with you right now is the fact that we as caregivers are critical members of the healthcare team. We don't wear white coats. We don't carry pagers, but we are healthcare team members. And our responsibilities are profound. And I just want to quickly highlight three of those. The first I already did acknowledge, and that is the fact that we are asking all of you to be physicians and nurses and physician assistants and to perform medical and nursing tasks. And I know this can be very overwhelming. I want to acknowledge we have in the United States today what's called the Caregiver Advise, Record, Enable Act, the CARE Act. It's currently passed in 45 states and territories. And it says three things, not four, three things. And it says that hospitals should document the name and contact information of caregivers in the medical record of patients when patients are admitted, that hospitals should let that caregiver know when a patient's going to be transferred or discharged. And very importantly, the hospital should provide that caregiver with training and instruction so they know what to do when they get home. Now, I know that even in states where the CARE Act is passed, it is not consistently implemented. So I want to encourage all of you who are caregivers to make sure to ask a nurse or other member of your care partner's health team to demonstrate for you all the things you're going to need to do at home. And then for you to actually demonstrate back those skills so that you can feel competent and confident to do so. I want you to advocate for your educational needs. You should not leave the hospital or not leave the clinic unless you feel comfortable to take on those responsibilities. I also want to acknowledge two other areas. One is case management. So case managers are by definition paid employees of healthcare systems who coordinate care, but we as caregivers do this free of charge, right? And these responsibilities range from coordinating care, navigating insurance and reimbursements, implementing home health care. And while some of these may not on their own be incredibly distress-inducing, although some certainly can if you're on hold forever, when we add these case management responsibilities on top of everything else, it can get overwhelming. I have found that these case management responsibilities are some of the responsibilities that are more easily delegated. So I would encourage you to consider, are there any of these responsibilities that you can delegate to other members of the care network? And finally, it's rarely talked about as a responsibility, but I certainly have found it is, and that is healthcare communication. We as caregivers are tasked with engaging in incredibly important conversations with our care partners, with members of the medical team, about care now, care in the future, about this umbrella term, what we call advanced care planning. And these conversations can be very, very difficult and overwhelming. Sometimes they're the most difficult conversations we as humans can have. And I just want to acknowledge this as a responsibility and to say that if you're struggling to have discussions with your loved one about their health care, this too is an area where a mental health professional can be really, really helpful. I want to end by acknowledging, of course, I stated the burden and distress that caregivers experience. And of course, this is why I do the work I do. But I also want to acknowledge the fact that despite that burden and distress, caregiving absolutely provides an opportunity for you to connect to meaning and purpose. It's not all bad. I'm not talking about the power of positive thinking or turning lemons to lemonade, but I am acknowledging that in situations in which we feel powerless, in which we might not have had a choice, such as caregiving, those are also opportunities for us to connect to meaning, to learn new things about ourselves, to have a strengthened relationship with our care partner or others in our life, to refine our values, and to grow. I have yet to meet a caregiver who has not derived some strength as a result of their experience of caregiving. And so that is my wish for all of you, that today and moving forward, despite whatever challenges you are facing, that you are also able to connect to meaning and purpose that is available to you through caregiving. Thank you so much.
Thank you. It's always lovely to hear from you, and you provide such great information. Our next panelist will focus on managing the caregiving challenges presented by a prostate cancer diagnosis and treatments. Dr. Andrew Roth is board certified in psychiatry and psychosomatic medicine. He is an emeritus member of the Psychiatry Service, Department of Psychiatry and Behavioral Sciences at Memorial Sloan Kettering Cancer Center. During his tenure as program director for the Psychosomatic Medicine and Psycho-Oncology Clinical Fellowship Training Program at MSK, he received awards for clinical and teaching excellence. He concurrently worked as a professor of clinical psychiatry at Weill Cornell Medical College, Department of Psychiatry, and was an attending psychiatrist at New York Presbyterian Hospital. Dr. Roth's research led to the development of the distress thermometer, one of the main tools used worldwide for distress screening in cancer settings, and the creation of the Memorial Anxiety Scale for prostate cancer. He is the author of the book, Managing Prostate Cancer, A Guide for Better Living. Today, he will present the emotional judo skills and strategies necessary to help patients and caregivers deal with the challenges that a prostate cancer diagnosis and treatment bring to everyday life. Welcome, Dr. Roth.
Thank you, Karen. Good afternoon, everybody. It's a pleasure to be part of this esteemed panel for today's symposium on dealing with the emotional aspects of prostate cancer. I've worked with many men with prostate cancer and their families for almost 30 years to help them cope with the diagnosis and treatment. It's difficult and challenging to go through the physical and the emotional changes related to prostate cancer, changes that are often unpredictable when we're looking for more certainty in our lives and in the future. Many men resist the idea of psychological help, but getting help doesn't mean that anyone is crazy. However, emotional issues can really get in the way of better cancer treatment and can therefore make coping with the cancer much more complicated. Psychological support may facilitate better accommodation to a changing life, as well as better communication with doctors, with family and friends, and therefore perhaps even with getting better medical outcomes. Men don't want to worry their families or their doctors, so they often hold stuff inside, but it's often very obvious and counterproductive. Prostate cancer usually doesn't mean imminent death, though people may act as if it does, so that every moment, every decision, every test result feels like it's a potential life or death issue. This can lead to ongoing distress, heartache, and sometimes procrastination and uncertainty. That's a tough way to live every moment, upset about the past or wondering about how things will go in the future, because no one, not even the best doctors, have a good crystal ball to know the answers to reasonable questions like the following. Will I be cured or not? How long will I live? How could this happen to me? My father lived to 95, and I took great care of myself. Men can worry and obsess about treatment decisions, and their caregivers are hearing about these all the time. What will give me the best outcome in terms of longevity? What will have the fewest and least problematic side effects? What side effects will I get? Which side effects could I deal with, and which ones can I not deal with so well? How come the experts all have seem to have different opinions? What kind of man will I be if I can't get erections, without sex, and possibly if I grow breast tissue, if I get hormonal treatments? Am I going to get to see my kids get married? Will I see grandchildren? How could God do this to me? This isn't fair, and I don't deserve this, and frankly, we don't deserve this. These questions, statements, uncertainties that surround life or death may be understandable, but they bring up emotional reactions such as frustration, irritability, anger, anxiety, irritability, sadness, depression, fear. And did I mention irritability? I think I see many caregivers describing the fact that their husbands, their partners can become so frustrated by what they can't do, what they used to do. And the emotion comes out as irritability. Some men feel weak or embarrassed by these changes and emotions, and they won't talk about them, but they communicate their frustrations through complaining, through nonverbal behaviors like social isolation or avoiding family and friends. Many men feel that the options and decisions that they're facing are in an all or none type of aspect. And that kind of obscures the real reality. They might think, I'm either going to beat this cancer or I'm dead. If my PSA goes up, that's the end. It's all or none. And they may spend countless hours with Dr. Google online searching for the newest treatments rather than relying on their physicians who've seen many patients before with the similar issues that they have and who know them, the patient, well. If life becomes only about the cancer, it may cloud the potential for experiencing joy. For some men, the fear or concern that every new pain or symptom may be a harbinger of the cancer returning or progressing or of potential death. And that's not uncommon, frankly. And for men with metastatic disease who are on hormonal treatment, it can be difficult to accept some of the side effects that impact sexuality, loss of libido, difficulty with erections, fatigue, hot flashes, tearfulness, and sometimes even cognitive slowing. They may not even realize a growing physical and emotional separation that is becoming between themselves and their partners. Sometimes this will help the partners get used to, they think that this is going to help their partners get used to not being around if they happen to die. But usually it has the opposite effect. Partners are just feeling more and more isolated. But men can learn the importance of focusing on intimacy rather than just sexuality as they've known it, and they can adjust to changes brought on by the cancer or treatment. Attempts to grin and bear it may more often look like grimace and suffering. There's no magic remedy for better coping, but recognizing and identifying if there is an emotion present before it feels like it's out of control may help a man short circuit a worsening emotional spiral. Relaxation procedures such as mindfulness breathing may help. Men can also learn methods to avoid the thought traps that prolonged worry rather than resolve it. And frankly, if men can learn it, their partners and caregivers can learn them as well. I used a combination of supportive psychotherapy, cognitive behavioral therapy, problem-solving therapy, and acceptance and commitment therapy to help patients with all stages of prostate cancer understand and practice these techniques. I call this emotional judo. It seemed like it was a great visual for the men I were taking care of who often were not as in touch with their emotions, but very physically oriented. And if there's a big bad opponent out there, and it's the cancer, or it's the treatment, or it's death, if I feel like I'm going to try to beat it up, it's going to knock me down. And if I feel like I should run away from it, it's still going to be there tomorrow, and maybe even later today. So what I did was to come up with a term called draft, DRAFT, to help men remember the key aspects of this process, which many men know from sports, where good players from colleges are selected to join different professional teams. Draft stands for the D, detect. Very often we have the emotion, guys, maybe all of us at times, we have the emotion, but we're just not aware that we're having that emotion. Or we're not aware of the thoughts that are going on in our mind that are getting us so upset, or even some of the behaviors that we're doing. Frankly, when I'm not feeling well, I can have a tendency to be irritable and angry. And people usually say, if you're getting angry, you should count to 10, and that will help calm you down. Well, what often happens with me, and I think some of the patients that I would take care of, is I would blow up, and then I'd start counting to 10 to try to calm down. It was kind of backwards, and I am a psychiatrist, but the reality is sometimes the emotion just comes out. And so the more we're able to help someone recognize the situations and the vulnerabilities and what those emotions feel like, maybe we can get a handle on them. The second phase is to recognize, the R, recognize that there are rational and irrational aspects of our emotions and our thoughts and our behaviors. I might feel that, I'm not going to live as old as my 100-year-old grandfather. And that's not right. I thought I was going to get 100 years plus because I take good care of myself. That's a rational thought, and I might feel sad about that. And if I can recognize that, quite understandable. There are some guys who might say, if I can't play 36 holes of golf anymore, like I've done for the last 30 years, what's the point of playing at all? And they give up. They give up something that might have been a lot of joy for them and might still be quite pleasurable. Just getting together with 3 other buddies on the golf course on a beautiful day can bring a lot of joy. But they say, if I can't do it the way I used to, forget about it. The third phase is acknowledge what's behind the emotions or the behaviors, and see how those emotions can pull you away from what you really want. The fourth phase is flipping. The F, flip your attention away from the distress that is frankly in the past or it's in the future, and back to the now, back to the present, perhaps with a however statement. Yes, my PSA went up and I'm worried about the future. However, I'm okay right now. My family is okay. And I don't want that worry to steal a better life from us today. What can I appreciate about my life right now? The last phase of draft is transformation. The T, transform through relaxation or distraction, or a quick list of activities to do that might be more pleasurable and meaningful in the moment. So when someone is feeling calm and not emotionally wrought, I would have them draw up a quick list of activities that they can do, that when they start to feel the emotion and swelling, they can go into their back pocket and pull out that list of activities. And it might be put on some music, put on a ball game, go out for a short walk, give one of my kids a call just to talk, get a puzzle book and do a few of them, play a computer game, chess or solitaire, practice guitar, practice piano, go into your garden after the snow melts and start pulling weeds, call a friend, make a lunch date, get a massage. Have patience, have mild persistence, and take breaks when it comes to activities. I like to say, start low, go slowly, but go. You can think about rearranging social engagements to allow for decreased stamina or increased discomfort. For instance, I think it's okay, and I've had patients do this, where they can go to half of a concert, where they can streamline church services, or just go for a walk up and down the block, even for someone who used to jog regularly. And it feels like, boy, Look how the mighty have fallen. But taking that walk for where you're at today is very important. It's very important for your physique. It's very important for your emotional health. And some engagement and enjoyment is usually much better than none. And lastly, I think men with all phases of prostate cancer can find life-changing benefits by thinking of themselves as role models. And I know this sounds pie in the sky in the face of cancer. However, I've seen it bring families together, and I've seen it improve men's self-esteem. Our children, our families, our friends are going to face challenges. Maybe they're career challenges, maybe relationships, maybe cancer, and maybe even something worse. If we can act like realistic role models now, not Superman, not Superwoman, but in the face of our adversity, we can teach those who are watching us to deal with challenges and perhaps demoralizing life circumstances in the future that they can't even imagine today. Psychotherapy can be helpful to figure out how to better manage the intrusive and unwanted changes that come into your lives that cancer may bring, and to find more intimacy and to deal with the looming human issue of mortality. Get support from a social worker or a psychologist or a chaplain if needed. Psychiatric medicines may be helpful for one or both of you to figure out how to better manage the intrusive, unwanted changes in your lives. Trying to keep a realistic, positive attitude, as Dr. Applebaum mentioned, it's not easy. In fact, people will say, be positive, but it's not very realistic much of the time. Doesn't mean you should be negative, but it may be useful to validate your partner's frustrations and your own, while also trying to see the glass as half full. But don't expect your attitude to be stable and consistent for you or for your partner, because they're not going to buy it if it's always positive in the midst of difficult news. Take a breath, try to take your own emotional pulse, and then start again if needed. Thanks for your attention.
Thank you so much, Dr. Roth. That's great insight for the caregivers to men on the prostate cancer journey. Nicole Stout is our next panelist, and she is the Senior Director of Survivorship and Wellness at the American Cancer Society. She leads a national portfolio of strategic initiatives in lifestyle medicine and caregiver support across pediatric, adolescent, and adult oncology. She has an international reputation in cancer rehabilitation and survivorship care, with extensive experience in clinical research focusing on supportive care delivery in cancer. Her research has been foundational in developing the prospective surveillance model for morbidity management in cancer care. She lectures nationally and internationally. And in addition to authoring and co-authoring pieces for peer-reviewed and invited publications, she has contributed chapters to several books and is the co-author of the book 100 Questions and Answers about Lymphedema. Dr. Stout has led national and international strategic initiatives advancing survivorship research, guideline development, and policy solutions in cancer care. She is an adjunct research faculty member of the West Virginia University Cancer Institute, where she supports clinical implementation research. Dr. Stout will discuss the impact caregivers have on survivorship and highlight the supports and initiatives American Cancer Society has in place for caregivers. Welcome, Dr. Stout.
Thank you so much. It's great to be here with you, and really appreciated Dr. Applebaum and Dr. Roth's perspectives. I like the draft acronym, Dr. Roth. I appreciate that, and I wrote that down, and I'm going to take that to heart and use that. Thank you. Although I think some folks on the call, when you got to the F and you said flip, I went, some people might have a different way they'd think about flipping this whole cancer thing. You know, over the 30 years of my career as a clinician, I'm a physical therapist by training, and then as a researcher, I've always been the person who spends a lot of time one-on-one with the patient and their caregiver. but I'm not the one that they're supposed to talk to about the emotional problems that they're experiencing or the challenges that they might be experiencing in their relationships. But somehow, because I'm not supposed to be that person, I become that person by virtue of the time spent. And I've learned tremendous amounts from my patients about managing the way that they manage and the way that they deal with the emotional aspects of cancer. And the caregivers in the room are always it's always my favorite to have a caregiver in the room, because many times I ask the patient a question and I get this, and then I see the caregiver in the corner going like this. And so it helps me to broaden the conversation always. And I think that's an important point for caregivers. You are a part of the conversation, you're part of the story, and providers need to hear that part of the story. You know, cancer, prostate cancer specifically, the trajectory, the landscape of treatment has changed so dramatically in the last 20 years. And the trajectory of cancer care for prostate is different. It doesn't always start with surgery. It doesn't always start with radiation or start with hormones. It's different for each patient. And the trajectory of that care and those punctuated pivots that happen, I think, can be incredibly frustrating for the caregiver. The caregiver's along for this ride, and when those changes occur and those pivots happen, the caregiver feels like, okay, we got this. Keep my head down, keep doing the things that I can do to support. I think it's important for you to be given license to feel your own feelings. And that may be the frustration that you're feeling, the anger that you might feel when things have to pivot and change, and that's okay. That sometimes we put our heads down and have to just feel like we have to barrel through because we don't want to upset our loved one. We don't want them to be more stressed because they're seeing us as a caregiver experiencing these emotional highs and lows. So we hold those things inside. We hold back on sharing our anger. We hold back on sharing our exhaustion. And I think it's important to recognize that for you as a caregiver, you need to have you have license to feel those feelings, to be angry at your spouse when you feel that, and identifying ways that you can find support to manage those feelings. That's the important piece of this. I like to say, many patients have said, and their caregivers feel like, I am a glass half full kind of person, but you keep knocking my damn glass over, right, at every one of these pivots and punctuated changes, and there's only so much that I can take. And that buildup is a very real, realistic reality we have to face as providers working with the patient and recognizing that the caregiver who's sitting next to them, they're right there and they're ready to, maybe they're at their wit's end, maybe they're at their edge, and they're trying so hard to hold it together for the sake of supporting the patient. And so I would encourage caregivers to know you are part of the story, to speak up and ask the questions that go along with your part of the story, and to know that there are resources for you dedicated to you. You're probably given brochures and handouts and educational material about all of the treatments that your loved one will experience, about all of the side effects that you should be looking for, and what will have to happen to manage those side effects. You're scheduling the appointments, you're going out and picking up things from the pharmacy, right? You're doing all of the tasks that you need to do to support your loved one. Absolutely. And you do that willingly, and undoubtedly it fulfills you. But recognize that there are resources for you. There are resources to help you emotionally cope. There are resources to help you grieve. There are resources to help you find a pathway to light, find a pathway to experience mindfulness, experience meditation strategies, experience exercise strategies that can help you in your coping. Because coping is dynamic, because the trajectory of cancer care is dynamic. You may wake up one day and feel like you can take on the world, and you're walking alongside your loved one. And then you may wake up the very next day and feel completely opposite. And the anger and the frustration that you're feeling perhaps with them, and why you're being put through this. So there are resources for you as the caregiver, and more the medical establishment recognizes We need to develop stronger programs, stronger linkages, stronger materials and resources dedicated to the caregiver, because treating the patient, managing the disease is part of the story, and you are a part of that story too. The other thing I encourage is giving you license to ask the second question. I think many times we go into our doctor's appointments and we have our list of questions and we get a response, but maybe digging deeper and not feeling hesitant to ask the second question. Can my loved one exercise? Oh, sure, exercise is good. We know that individuals who have cancer, it's safe and it's good. Next question is, what does that look like? What can we do together? What are the safety parameters we should be thinking about with exercise? Are there nutrition considerations that we should be thinking about? And the response from the provider might be, oh, sure, fruits and vegetables and healthy fibers, make sure you eat those. And the next question might be, well, what does that mean, right? Help me to contextualize that. You as the caregiver should have take license to ask those second questions and to be able to best support your loved one. We know that many of the lifestyle medicine interventions, good sleep, healthy eating, managing and reducing stress, and exercise, the evidence base has escalated significantly, especially in the prostate population. And many times exercise groups can become support groups for both you and your loved one. Some of the exercise evidence suggests that the dyad, the spouse, the husband and the wife, the partners, the spouse of the individual going through cancer, when you exercise together, it is not only beneficial physically, emotionally for the patient, but also for you as the caregiver. A dyad that exercises together stays together. We tend to see better relationship strengthening and outcomes in those individuals who exercise together. So giving you license to say, we need to do this and we need to do it together. The other aspect that I know as a caregiver sometimes, and especially being a little bit of a type A personality, but even just knowing how your life is structured and set up, for you as a caregiver, sometimes you feel like it's just easier for me to do it myself. It's hard to hand something off to someone as well-intentioned as they may be, willing to step up and to help, taking someone to an appointment, filling a medication at the pharmacy. It's just easier for me to do it rather than having to coordinate with someone. I think, and my end statement really was for caregivers to feel empowered. And in order to do that, you need the resources to help you. So at the American Cancer Society, cancer.org is your friend. We have a plethora of resources, not only dedicated to help you learn about cancer as a disease, treatment side effects, but also for you. We have developed a cadre of resources dedicated to you, the caregiver. How do you cope? How do you find strategies for mindfulness, for rest, for respite when you need it? Our hotline, 1-800-227-2345, easy to remember, is a 24/7 hotline staffed by knowledgeable nurses and medical professionals who can not only answer your questions about the cancer treatments that your loved one is receiving, but can help you to find resources, many times in your local community or through your local health system, that can help you to deal with and to help you manage some of the stresses that you are experiencing. So I'll stop there and let us move into Q&A, which you've already done, but I did want to suggest that the American Cancer Society resources, we have dedicated prostate cancer resources, side effect resources, respite care, caregiver resources, etc. So we really are a one-stop shop, and it's all free.
Thank you, Dr. Stout. I'm sure a lot of people have taken down that information and will tap into those resources. So we're going to, actually, we did not get very far in the question and answer period while you were offline, but we are so we're going to get it started right now. Everybody, please, any questions that you have, please post them in the, I'm not sure if you have a Q&A or a chat feature, and they will come through to us and I will pose them for you. So I have one question that has come through is, how can caregivers manage their own negative doomsday thinking, like anxiety about the future, worry about what might happen? This is a question that comes up all the time in the women's support group.
I'm happy to,
you.
yeah, I'm happy to start. And I know that at least Dr. Roth certainly will probably have something to chime in about. Emotions are messengers, right? They have something to tell us when we feel that anxiety, when we have those thoughts. That's because it's valid to have those feelings and because we're scared or we're sad. And so the first thing I want to acknowledge is that it's very important to express your emotions. It's a silly example, but if I say to you for the next 5 seconds, do not think about a bright pink elephant, it's very hard to not think about a bright pink elephant, right? I always see bright pink elephants, even so many years later, giving this example. So if we try not to think about the thing that's scary, results waiting in the portal, for example, we're going to actually focus on that more and more and more. And so my first piece of advice is actually to share the worries and the thoughts and the fears you're having. That can be sharing it with a therapist. It can be sharing it with a friend. It can be journaling, writing it out, speaking it into a voice memo. I actually don't care how it is you get it out. That's less important than the fact that you do get it out. And once you get those worries out, what can be really helpful is to take a step back, take a deep breath, and to look, especially if you've written them down. This is why writing sometimes can be really helpful. Examine the thoughts and say, well, is there anything here I have control over? Is there anything that I'm worried about that I can actually problem solve about? And if there is, then you can go into problem solving mode. And certainly if there isn't, then this is where practicing a lot of what Dr. Roth shared, emotional judo, and practicing what we call emotion-focused coping, doing the things to navigate difficult emotions can be really helpful. This can include things we can do to calm our body, like deep diaphragmatic breathing, taking deep breaths in through the nose and out through the mouth, practicing mindfulness, doing some exercise. All of these things can help. Expressing the emotion and sharing our fears can be really helpful. And what can be really powerful, I think, for so many caregivers is realizing that sometimes just opening a dialogue about what is causing anxiety, what is causing the fears and the worries, can lead to really productive conversations. Dr. Roth and I often had joked about when we shared cases back at Sloan Kettering about networks of silence, where I would treat a caregiver and he would treat a patient. And the caregiver wouldn't want to open up a conversation about her fears about X, Y, and Z because she didn't want to upset her husband. And Dr. Roth is treating the husband, and the husband wants to talk about X, Y, and Z, but doesn't want to share them with his wife because he doesn't want to upset her. So both patient and caregiver are both avoiding talking about an elephant in the room. What we find is, though it can be difficult to open a conversation to say, I'm really concerned about what if those test results don't look good? I'm really concerned about how we're going to move forward. While that can be scary to open that discussion, doing so is going to lead to an incredible amount of vulnerability and connectedness and likely problem solving. So the more you keep it to yourself, the more difficult it is to sit with. I also just want to acknowledge, I know I said this earlier, that emotions are important. They're messengers. They're valid. Feeling fear, feeling sadness, these are all appropriate. And so I just want to acknowledge again that sometimes simply just expressing them out loud can be really, really helpful. And again, whether that is appropriately with your care partner or if it's with a friend or someone else, it can be really helpful just to get it out. I don't know, Dr. Roth, if you want to add to anything I just shared.
No, I think that's important. When I would have patients make appointments with me, very rarely was a couple the people who were made the appointment for. It was one person. It was the guy who has the prostate cancer. And I would go into the waiting room for a new visit and I would say, Mr. Smith. And I'd look around and 2 people would stand up. And I'd go and I'd get introduced to the partner and I'd start walking back with Mr. Smith and 2 people were following me. And I'd say to Mr. Smith, do you want your partner to come in with you? And he might say, well, they're the reason I'm here. So yes, and we have no secrets, of course. So yes, I'd like them to come in. And so I would have some of the session with the couple and some of the session with just the patient. And it was very important to understand some of the secrets, the things that people were afraid to share. But when you ask the question and you get into that situation where, one is saying this and the other is saying this, you can open that up and try to get each to see the others, maybe not agree with the other's way of thinking, but yes, there's some common ground there. And I think that those kinds of discussions can be very helpful. I also think that sometimes, couples don't have great communication skills or great communication history. And I think that's where the idea of journaling, where you can get some of those thoughts and emotions down on paper, where they're not just rolling around in your head all day long, can be very helpful. It's unusual for anyone to find that very helpful family or friends who say, don't worry, is going to actually lead to don't worry. Someone says, don't worry. That's when my antenna go up like, oh, what are they trying to hide from me? And so I think being able to discuss some of those issues and unravel them can be very helpful.
Thank you, Dr. Roth. Couple of questions have come in. So one says, I'm looking for more guidance about relationship care. Many of the caretaking issues have been listed. Please address the intimacy aspect of relationships after prostate treatment, libido changes of emotions for both partners, the effect of prostatectomy and/or androgen deprivation therapy on sexuality, changes to the female partner's response when there has been physical distancing.
Yeah, I think this is very common. It's one of those things that even before cancer happens to a couple, sexuality may not be the easiest conversation topic for them to have. They may engage in sex, they may enjoy sex, but it's not always the easiest thing to talk about. And so when a man is going through these changes, and no one can predict before the treatment which side effects they're going to get. Will they get erection issues? If they have radiation, will they have erection issues down the road, months or years later? It's like playing a game of roulette where you're not sure what's going to happen. But once it happens, I think men do go through a period, Dr. Stout mentioned grieving, and for something that they have lost, but it doesn't mean that, well, that's done with, no more intimacy. There have been a number of studies of couples who didn't have cancer, but also who do have cancer in their lives, where they're able to take some of the burden and pressure off of the sexual performance. And that's where, guys are often at, I get interested, I get an erection, we have sex, I have an ejaculation, everything is great, bam. And that for them may be intimacy, but what they're not seeing is that even without the sexual act, there can be a great amount of intimacy, a great amount of love, and a great amount of warmth and compassion, so that being able to help a couple pull the pressure away from the performance and start to just touch each other in the non-erogenous zones, to touch each other a little by little, and to enjoy the hugs, and taking the idea that, hey, if I'm not having an erection and if I'm not having an ejaculation, what's the point? Well, there is a very strong point, because it's such an important part of couples' health to be able to share that intimacy. It may take a while for a guy to buy into it, but there are not, I haven't had that many arguments with me from patients, and that, it may not be their druthers, and they may always be comparing themselves to the past, but they might actually find that there is a lot of warmth and joy in the hugging and the snuggling, that they thought, what's the point? They actually find there's a very important point to that.
This is a big topic of conversation within the women's group, the women's support group. And I've had one woman who, on a consistent basis, has said, all I want him to do is hold my hand. That's all I want. I just want him to hold my hand. And it is, it's physical touch is tied to so much intimacy that
I once gave a couple a homework assignment that when they were going back home on the bus, I wanted them to hold hands on the bus because they had been like physically distant. And they actually did it. And they came back and said, boy, that was kind of nice. So step A.
Yeah, exactly. Exactly. Here's an interesting question. Any tips to help support my husband and myself as the caregiver with the significant cognitive issues posed by post ADT? I don't want to cause him to feel even worse, but it's so hard all at the same time.
Yeah,
Um,
that's a rehabilitation issue. Cognitive behavioral therapies have been shown to significantly improve memory loss, short-term memory loss, brain fog, many of those hormone-related cognitive changes. You can certainly find cognitive behavioral therapies that are delivered through evidence-based apps, but I would suggest starting with a rehabilitation professional, an occupational therapist. There are cognitive and behavioral health certified specialists in rehabilitation medicine. You can certainly connect with them, referrals. Many of them you can see with direct access without having to have a referral. But they're important strategies in a very evidence-based and succinct approach to helping with regaining memory and regaining cognition through behavioral therapy techniques.
Sometimes the cognitive slowing may be a function of the hormones directly, maybe the fatigue that the hormones can cause. And so I think it's not a bad idea to have that rehabilitation for someone to understand, and maybe even to chart out when they're having some of those cognitive issues and what's going on at those times. We did a study a number of years ago using psychostimulant medications for men with prostate cancer who were having fatigue and some with cognitive slowing. And we found that the medications were safe, if we're using them safely in the right population. And so sometimes that will help if the rehabilitation that Dr. Stout was talking about isn't working sufficiently. If a patient can tolerate a medication, it might be a good alternative for them.
It's interesting that you bring in the fatigue aspect. And when you look at the immense body of evidence around fatigue management across all cancers, exercise really rises to the top as far as helping to mitigate fatigue, but very closely linked to cognitive and behavioral therapy. And in fact, when you use the two of those together in a structured rehabilitation plan of care, that's when we really see optimal outcomes. So I do think, and I see several questions in here about sleeping a lot, being very fatigued. Sometimes the fatigue causes the brain fog. The fatigue perpetuates more fatigue, actually. And so rest is not best frequently. The activity, does the exercise help to feel more mentally stimulated? Are there neurotransmitter uptake changes that occur that make them feel better, that make them think more clearly from the exercise? Is it the cognitive behavioral therapy that makes them feel more energized and so therefore they exercise more? At the end of the day, a large body of randomized controlled evidence suggests exercise combined with CBT, the cognitive and behavioral therapies, not only for the brain fog, but also for that fatigue management. They really do go hand in hand. Fatigue is not just about being tired and needing to rest more. There are central and then there are peripheral mechanisms that drive fatigue according to, our current evidence. And so the combination of the movement and exercise with the cognitive strategies really seems to be an optimal approach.
Those are great points. And I think, some of my patients used to wonder, I thought you were the psychiatrist. Why am I walking out of here with some exercise? I would make sure that the physical therapist came up with the routine, but they always heard from me that you have to be walking, you have to get up, you have to be hydrating, you have to be doing, because sitting around is not going to, and resting is not going to replenish this kind of energy loss.
Thank you.
I just want to also, sorry, just to chime in, I saw the comments
please.
about the question specifically for somebody who's struggling to get their partner to get up and to do things, and she's working. And I just want to acknowledge that, yes, all of what Dr. Roth and Dr. Stout said is important. And absolutely, we want behavioral activation and cognitive behavioral therapy and exercise. More energy begets more energy. And also, it can be really overwhelming and distressing and frustrating to have to be the nag, to be the person to continually to tell someone to go do the thing is going to be helpful. One thing caregivers with whom I've worked has found helpful is really hooking in members of the medical team to be the messenger. So if your partner, your husband's not listening to you, one thing that I would suggest is reaching out to his team and letting them know about his sluggishness, let them know that he's sleeping this much, and ask them to actually relay the message of how important it is that he gets up and about. And oftentimes that can move the needle a little bit more.
I was actually going to ask the same question.
Okay, great.
So another question that came in is, are there any techniques for a new caregiver to help stay positive and establish a welcoming bedside manner?
I'm going to go back. It's great. I already gave you my elephant in the room example. So it is really hard to just stay positive and be positive and rah, 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 and keep your pom-poms going when the reality is you're really freaking out inside, right? And yet I recognize fully, of course, from my own personal experience of how important it was for my dad, for me to have that positivity when I was with him, especially at the bedside in the hospital. The only way that you can do that healthfully is if you are truly getting out all of those fears and concerns and worries, which may be valid, in advance of slapping on that happy face. That if you're putting on that happy face at the expense of neglecting and ignoring your true emotional experience, then your distress is just going to increase, and it's going to be really, really hard to do so. And so I think that you can do that. I certainly would encourage you to do that forever and ever, all the time, especially if there are things that are happening that are causing realistic worries and concerns. But again, I think it's really just important that you find the safe space where you can be authentically you and express what's really coming up.
Dr. Roth, Dr. Stout, do you have anything to add to that?
I think just going back to what I said, just understanding, I think sometimes to stay positive, you've got to let the negative wash in and then wash out, right? In order to find that positive space, because trying to force yourself into staying positive all the time becomes a burden, becomes an energy suck of your own, and truly is not reflective of how you're feeling. Letting those true, authentic feelings happen, and finding the strategies and ways in supportive ways to help you let that anguish, let that frustration wash in, wash over, and wash back out. I think that probably helps substantiate and maintain that positive over the long term, which is what you need.
I think it's being a caregiver, like so many other things that we do, is on a learning curve. But the learning curve, as I understand it, is not always very linear. And so, we think that it's not okay to make mistakes. We're so worried that we're going to do some harm to the person we love. And I think, being able to ask questions of the medical team is very useful. If I'm really not sure, Dr. Applebaum mentioned before, the training that caregivers could certainly use before they go home and have to change appliances and do all kinds of things that nurses may have done in the past. I think it's okay to call. It's important to call and say, I'm really not sure about this, or I need some help with this. And then, there is that learning curve, and caregivers do get much better at doing what they're doing, because none of us are born as caregivers. I didn't go to school for that. None of us did, and we don't have a diploma. And yet I think there are a lot of caregivers who could teach a lot of healthcare professionals about caregiving, because they've learned some of the intricacies of what works and what doesn't work. So I think it's a matter of not giving up, not throwing in the towel, keep trying and asking for help if needed.
Excellent advice. And I have a follow-up question to that. I don't agree with my husband's choice of medical provider and have difficulty communicating with the doctor because he shuts me down during appointments when I try to ask questions. But my husband doesn't want to ask the questions either. What can I do?
Well, there's a conspiracy of let's not talk about this. And that may be where a session or a few sessions with a therapist, a mental health therapist, would be useful. A lot of the men don't want to look like they're complaining. They want to feel like they're in the best shape as possible, and they don't want to admit to their doctor that their energy isn't so good or something else. So that's where we have the head shaking this way and the head shaking the other way. But I think it may be very useful for a therapist to be able to hear these and maybe to discuss how some more common ground can lead to some improvements of things that are frustrating for both in the couple. I don't know that there's a magic remedy for that, but I think not just throwing up one's hands, but trying to work at those issues can give some good results.
Thank you. Thank you. There's a follow-up question from the, positive attitude and glossing things over. And the question was, my husband is the one with the positive attitude. I'm the one who's often upset, and he supports me. Then I feel guilty. Then I downward spiral because he's supporting me, but he has the prostate cancer. How can I change this pattern?
Again, my advice is going to be the same. This is definitely a situation where maybe seeking professional support could be helpful. So you have a really sturdy forum to get your worries out. And then, it sounds like there's some added guilt coming up for you in terms of him sort of having to support you in your emotional experience. So I would actually just suggest making sure, if you don't have professional support, seeking professional support, finding a space weekly to be able to get those concerns out. Many caregivers with whom I work also find it can be helpful, especially if they want to protect their care partners in some way from what they're feeling and their negative emotions, to do what we call worry time. This is scheduling a period of your day, maybe 10 minutes, 15 minutes, 20, where you purposely sit in your worries and think about your worries and get them out, to what I've been saying again and again today. I'm a broken record. But to purposely do this at least once a day to give it a little bit of an outlet. And sometimes caregivers will find that when they schedule this, let's say, okay, I'm going to spend from 9 to 9:30 every morning in worry time, they may find that they're better able to be less distressed in the presence of their care partners during the day. So I would encourage you to, number one, seek professional support. This is a great sign that it can be helpful. And number two, see if engaging in specifically scheduled worry time could be helpful as well.
I might also point out that not all couples are the same, and that's for good. But there are some times where, even though the guy has the cancer, it can be very useful for him to feel like he can still take care of his partner and provide that emotional support. And, Dr. Applebaum mentioned the guilt, and maybe that's something that they can work on in terms of, yeah, we're coming at this from different points of view, but we're figuring out how to take care of each other. And maybe that's the most important thing that they can get out of some therapy, is to recognize the shoe doesn't have to always be on one foot or the other, but there may be a balance that they can find.
Thank you. Thank you. Dr. Stout, there was a question that came in. Family caregiving is essential, but you are spot on about the emotional stakes in play that can sometimes lead to anger and other difficulties in coping. Do you have any recommendations for dealing with the patient's volatility?
Well, I would say that is probably more of a Dr. Applebaum, Dr. Roth question. Personally, in having been on the receiving end of a little bit of a hostile type A father and being a caregiver for him, sometimes they want to feel heard. My experience is sometimes he needed to vent. Sometimes I used to describe it as I just let him vent, let him feel heard, and empathize with that. I don't have to fix the problem. I don't have to solve the problem. I don't have an answer, but I want him to feel heard for sharing the things that he's sharing because that's his way of emoting. I do think sometimes, and I will hand off to the experts, but in those types of situations, sometimes it is helpful for him to have a professional come alongside and talk through some of the issues that they're facing, especially if it is a hostile type of a situation.
That was great advice, Dr. Stout. So thank
From
you
the
for
physical
that.
therapist.
Thank you for that. One technique I would recommend is a communication technique called the XYZ technique. Imagine a Mad Libs. I feel X when you do or say Y because Z. And to use that to frame opening a dialogue with a care partner who might be expressing an intense amount of anger in a way that's very hostile and potentially inappropriate, and it could even move into the realm of abusive, to say, I feel really scared when you, or it upsets me when you yell because, and go through that X, Y, and Z. It makes me feel. And being really clear about why. And I think particularly when a caregiver is doing so much to take care of a care partner, often putting their own needs on hold, facing all of the losses in the relationship that have been articulated today, it is extra painful to be the recipient of anger. I also want to acknowledge that in most cases, beneath anger, there is a very deep well of sadness. Anger is rarely unidimensional. And so oftentimes in situations where there is a lot of anger, there is a lot of hostility, it can be really helpful to say, I know you're sad. I know this is hard. And to label that and to bring that into the room and to give your loved one permission to grieve. Again, grieving can happen far long in advance of a death that may never occur. Grieving the losses in the relationship, the changes in one's physical functioning, the day-to-day losses that happen. And so I think, number one, it's really important to express how you feel and to share why it's not okay to be the recipient. And number two, to acknowledge that often that anger is on top of something much deeper and much more powerful to be expressed.
One thing I'd like to add is that, and this isn't just with prostate cancer, it may be with all cancers and maybe with many illnesses, is not everything that looks psychiatric, someone getting irritable or anger, is psychological. Very often there can be aspects of someone's treatment. With chemotherapy, a lot of guys are getting steroid medications. If they have pain, they may be getting pain medications. The pain itself or the pain medications can make someone more irritable or more angry, quicker to blow a fuse. And so rather than just assume this is someone's psychological coping with their illness, it is something to be able to bring up with the medical team to find out, is something else going on, and medically. These men could be on many different medications, et cetera, and all of those can tip some of the emotions that are coming out.
The other aspect of cancer broadly, Allison, that I think underlies a lot of this also is fear. There is, and I did see a couple of questions that came through about the fear that just lingers over you, that constant fear of recurrence, the constant fear that this comes back, that it comes back worse. And you know that underlying that it's very different than other chronic conditions and chronic disease. The fear that cancer that is the cruel mistress lording over you for really for the rest of your life, and that unknown of when and if it comes back is a very real emotion that I think can elicit that anger as well, right? The sadness that accompanies the loss that someone has experienced, but also the fear that is just innate in the trajectory of what is cancer.
Absolutely. Absolutely. Thank you. One question that came through, we've talked a lot about mental health professionals and finding mental health professionals. Are there any resources out there for finding mental health professionals, especially those who are knowledgeable about the specific challenges of, caregiving to cancer patients and especially prostate cancer patients?
We
I don't
do
know. No,
have we do have our National Cancer Information System, NCIS, who those are the folks that answer the phone when you call the 800 number for the American Cancer Society, 235-245-2345. I'll put it in the chat for everyone. But they can connect you to resources and local resources, right? We work with many organizations like findhelp.com, but we also work with a curated list of professional organizations that provide information on licensed social workers in a specific geographic region. So we have resources that we can help to guide you to and connect you to in your local communities.
Excellent. Thank you so much. Um, Along that line, it was mentioned that we should, as caregivers, monitor um, thoughts, our own thoughts, depression, suicidal ideation. How do we detect those thought patterns in patients, in our spouses, in our, loved one that we're caregiving for?
it's a great question. And part of the answer may be a little bit unsatisfying, which is that every relationship and every individual is different. And so, number one, you likely do have a sense of what different emotions look like in your partner. There's no one uniform way that anxiety or depression present themselves. I think that Dr. Roth can speak a little bit about patterns that he's seen in his practice, so I'll have him do that in a moment. But just to say, number one, that you probably have a sense from prior experience about what those look like. When I read the comment in the chat about the husband who's sleeping all the time, the other thing that came up for me was wondering about whether he might be depressed. And so for many individuals who are experiencing low mood and depression, oftentimes that can manifest as sleeping a lot, like really lethargy, difficulty getting out of bed, difficulty getting motivated. And so again, this is where really trying to understand your own partner's history of these things. Now, the other piece is that mental health is not often talked about openly. And if you and your partner have not necessarily had a relationship for years and years and years where you have a dialogue about mental health, it might feel uncomfortable to open that now. And yet at the same time, this is the perfect time to do so. And one thing that caregivers with whom I've worked have found helpful is to start that conversation by saying, I've been having my own worries and my own fears. I can only imagine what this has been like for you. Would you be open to talking about it and trying in your own way to open a dialogue about what it has been emotionally to go through this prostate cancer journey? I don't know, Dr. Roth, if you could add just a little bit in terms of what you've seen in your practice?
It's not very standard. There are some guys who will be in touch with their anxiety and their sadness and their frustrations, and some who won't be. When a couple is coming in together, I do hear the he said, she said, and that is helpful for me to put some things together. When someone's depression may be related to other aspects of their illness, like fatigue or pain, I might ask the patient, if I had a magic pill to give you that would improve your pain, take away your pain, or improve your energy, what would you like to be doing? The person who's really, really depressed lifts their hands and says, I don't really know. The person who is less depressed and we're really frustrated about the symptoms might say, boy, if I can get some more energy, I'd love to go see my grandkids. I'd love to go out and take a walk. They have a sense of future orientation of what they'd like to be doing. That's not a hard and fast rule, but it has been helpful. Asking people what they're looking forward to. And looking forward to doesn't have to be 50 years in the future. It could be, you're such a great cook, my wife. I'm looking forward to what we're going to have tomorrow night. I'm looking into the future, those kinds of, and I'm looking forward to sharing a meal together. Those kinds of things, they may not sound like the most important, but boy, they could be the most intimate kinds of connections with people. So, and with anxiety, I think, we may know our partners well and their histories of anxiety or not having anxiety. Sometimes people can be worriers. Sometimes people can feel physical symptoms of anxiety. You can see if this is something that is a change for your partner in how they're expressing that anxiety, their angst. I've often asked patients to fill out charts. Mood charts, and you can put down 3 times a day, morning, afternoon, and evening, not just the mood, but how's my energy, 0 to 5, 0 to 10. How is my mood? How is my anxiety? Was I irritable? A few different things where they may be able to see that some things are going together at different parts of the day. When I am more fatigued, I'm more likely to be irritable. I don't know that you're going to find magic there, but often there are some nice nuggets of what's going on, even if someone keeps that chart for a few days or a week at a time. And frankly, I think the caregivers can keep their own charts because they're going to see some of their emotional connections with some of their physical and other variables going on in their lives.
Thank you. We're coming up on the end of our time, but there are 2 really important questions that have come through. And if everybody wouldn't mind staying a minute or 2 extra, I'd like to pose these 2 questions. A couple of people have posed the question that their husband is on androgen deprivation therapy, and it has rendered them impotent. And the husband is very comfortable with this, and they'll hold hands and be mildly intimate. However, their spouse is having trouble handling this, and they were looking for some ideas or some guidance, how to not sound like they're nagging, how to not sound like they're complaining, but to get the point across that they're upset about this. Any ideas?
Well, it's just go.
Go ahead.
I just want to say, number one, I just want to validate how painful that is. I just want to acknowledge how difficult this situation is and just to hold space for that because it is so very painful and it is such a profound loss in the relationship, what it means to be a woman and a sexual woman and have intimacy. And so I just want to acknowledge that. One can express sadness without nagging. And I think simply getting in touch with that grief that you're feeling, I'm hearing in the message, and that there's grief there, and just sharing that. And it doesn't have to be shared again and again and again, but I think there is value in expressing that sadness delicately at least once.
Yeah, it's not it's not that uncommon with androgen deprivation therapy. When someone loses the libido, they're not even thinking about going and holding hands necessarily or giving a hug. That is where I think therapy can be helpful to discuss that. And it may feel like, a bit robotic. Oh, I should be giving my partner a hug, every afternoon. But frankly, if the thought isn't occurring, it's okay to plant the thought, because I don't think it means that he is not loving his partner anymore. I think it means these medicines are having some effect on his ability to think about them. So discussing how they can move around the issues can be very helpful, and does not need to be embarrassing to anyone. To be very helpful.
Thank you. Final thought from all three of you. How can people avoid making caregiving their entire identity?
I love this question. It's actually something that I address with most caregivers in my practice. And I often will ask caregivers to imagine before they were a caregiver and to answer the question, who am I? And this can be any aspect of your life. It can be what you do for work, what you do for fun, what you do physically and exercise, et cetera. Who are you? Who am I? What makes us Allison and Nicole and Andy? Who are we? And then answer the question from the present time. And of course, I would imagine, because of caregiving, some things have shifted. And then I would encourage you to think about, how can you reconnect, even in small ways, to parts of yourself from which you have inevitably become disconnected. So maybe you cannot spend a lot of time in big crowds right now. You can't socialize the way you once did. Can you go for a walk outside with a close friend? Maybe you can't take that week-long vacation that you so very much deserve. And I hope every caregiver joining us today gets a week-long vacation. You all deserve it. Can you take 24 or 48 hours away? Can you take one full day just to yourself? Maybe you are somebody who used to go to the gym 7 days a week, and that's just not feasible right now because of all of the medical appointments that are happening. Well, can you still go to the gym? Can you still get that exercise in some way? I had a patient I always think about who she and her partner live far from New York City. They came to New York for medical care at Sloan Kettering. She was a gardener, and she found joy in her authentic sense of self by gardening and having her hands in the earth and working on the ground. And when they were living in an apartment in New York City for her partner's care, there was no garden for her to garden. But one thing we talked about was, well, what if you were to create window boxes and small plants for your apartment? That's not the same, but it allows you to get your hands in the earth and to reconnect you to that part of yourself who enjoys that. It's just one example of many, but I would encourage you to consider the question, who am I? And ask, how can I start to get back to that person? I don't want to put all of that on hold indefinitely. And I imagine there's something you could do right now to reconnect to that part of yourself.
Yeah, I think it requires purposeful intention. And that was going to be my response. Allison articulated that much more beautifully and specifically than I could. But it is that feeling of, I used to do these things, I can't do them anymore, I'm not doing them anymore. Maybe you don't do them in their totality, but you can find some way to pick up a book and read for 20 minutes in a quiet room by yourself. That's your time. Even if it's a reflection, journaling and reflecting on, these are the things that I'm going to try to do in the next week, in the next month, and set that intention and make it purposeful that you work towards that, I think is an opportunity that you could take to make those things happen.
Yeah, I think for any we've known that for any kind of a behavioral change, it takes like 5 phases. I'm not even thinking about it. I start thinking about it. I make a plan. I take some action, and then I start tweaking when it doesn't work. And I think it's very important to get out of the contemplation, the thinking about it, and make a plan, and make the plan and then fix it if you need to improve on it. Sometimes there are people in your orbit who can, if you're concerned about your husband being alone for some amount of time, a friend might be able to come over, or a family member may be able to come over so you can get that hour in the gym, or you can get some time at a museum or doing something on your own. I think it's important to be thinking and figuring out how to make that happen. And I imagine that's where organizations like the ACS can help people think through those kinds of situations where they're feeling maybe isolated or alone. The ACS has dealt with so many people who've had so many caregivers who've had these issues. They know so many options for caregivers on how to find that space for themselves.
Thank you so much, Doctors Applebaum, Roth, and Stout. On behalf of Fans for the Cure and the American Cancer Society, we are deeply grateful for the time you took to share your expertise and insight. This has been wonderful. Thank you to everyone who attended and participated in this first Caregiver Connection program. We will send out an email next week with a link to the full recording of this program and links to any resources that were mentioned today. Look for information in the coming months about other Caregiver Connection events that we're planning for the future, like National Family Caregivers Month in November and next year's National Caregiver Day. Have a good weekend, everybody. Thank you again.